All right. So, welcome to Airway Answers, expanding your breadth of knowledge. And we have Dr. Mariana Evans here. I'm so excited to have you on this show today, Dr. Evans. I'll read your bio, and I'm sure everybody already knows who you are. Dr. Evans received her DMD in specialty training at the University of Pennsylvania. To serve her patients better, she joined the University of Pennsylvania Sleep Surgery Department as adjunct professor. She is the founder of Ortho Institute, an interdisciplinary study club with extensive emphasis on prevention of oral and systemic diseases. She recently developed 4D morphotropic orthodontics, an innovative jaw expansion protocol with a focus on airway and periodontal health. Dr. Evans divides her time between her busy practice, teaching, and conducting research on the relationship between oral and systemic health. And I gathered your bio from an upcoming course that you're having, which I'd love to hear a little bit about that course. And today one of our focuses is going to be on expansion for the under 6-year-old population, which is extremely, extremely important. So thank you so much for being here, Dr. Evans. So, could you talk a little bit about the 4D morphotropic orthodontics and then the upcoming course that you're having that is, I see it's April 12th through the 13th, and it's called Innovations in Early Orthodontic Treatment, Revisiting Treating Children younger than the age of 6.
So thank you so much for your invitation to be part of this discussion. And I think talking about expansion for young children is really a very important step in facial development and facial assessment that we should all do, but it has been very minimally researched, and the research in this area is very limited because for 100 years we were looking on how to align the teeth, how to make them stable, and how to treat crowding. We didn't look at the jaw development from a very young age in terms of doing skeletal development for patients with airway issues, and we completely underestimated the value of early treatment for periodontal reasons. All the research that we have, for example, in periodontology shows that children in the primary dentition have much wider band of attached keratinized tissue around primary teeth as compared to children in around permanent teeth. And we never asked the question why there is a big jump in deficiency in the gum tissue from primary to the permanent dentition. Well, it turns out now that we have CBCT imaging to evaluate some of these skeletal problems, because I believe, based on my experience as a periodontist and an orthodontist, that gingiva, just like alignment of the teeth, if the teeth are crooked, it's just a symptom of a bigger problem. So the same thing goes with gingiva. If patient doesn't have enough gingiva, it's a symptom. It's not a disease. It's a symptom of a much bigger problem. And after looking at so many children, so many adults that have deficient jaws, I see a strong correlation between soft tissue or gum or periodontal deficiency and poor skeletal jaw development type of characteristics in these patients. So my course was developed over the past 12 years when I realized that we cannot use conventional tools to evaluate whether little children need to be expanded. And even if we agree that little children need to have jaw expansion earlier, how much to expand them? We have very limited research in this area, and I started to document a lot of cases and utilizing different tools to measure who needs expansion, who doesn't need expansion. And once I determined that they need expansion, how much to expand them. So I came up with the 4D morphotropic orthodontics, which is focusing mainly on jaw development. And once the jaw is fully developed skeletally with the orthopedic tools that we use, we position teeth axially in the bone, and then we engage those teeth in axial loading so they can be loaded axially rather than off axis, as teeth are loaded when the jaw doesn't grow correctly. And once they receive that axial loading, what we notice, actually very interesting, we notice that the bone around teeth gets stronger and is more visible on the X-ray, which every single study shows that there is less bone around the teeth after conventional orthodontic treatment with braces, for example. So we actually see the opposite, that patients, when we do this treatment in the right time, will have a thicker bone around the teeth when you combine skeletal development together with loading the teeth that are positioned axially in the bone. So it's very exciting. And I opened this course primarily for the orthodontists and pediatric dentists, because I think that the majority of these patients that will be treated under age 6 will be treated by a pediatric dentist, because they have the experience, they have the education to manage these children in the chair, utilizing all the new technologies that we have today, and being able in the best way to deliver very high quality treatment for these young children. And I hope that orthodontists also will do it younger rather than waiting till age 8 or 7 or after age 6. And maybe even some general dentists that like to see children and do already some very basic early treatment for children also will engage and do a service for these young patients and help their jaws grow in a younger age. So by the time they have permanent teeth erupting in the oral cavity, those teeth will have space and they will not erupt in compromising the periodontal tissues around them.
Yeah,
So this
that's
is
amazing. Like, I never really thought about that. So that's a
mhm.
thing that traditional orthodontic techniques, um, because maybe they're aligning teeth without attending to the skeletal components. So we're kind of teeth are compensated. Is that's what's causing the periodontal issues? Is because there's not enough bone supporting the teeth when they're not lined up straight in the bone. Is that correct?
So the interesting thing about development of the teeth is the transition. So a very big component of my course will be focusing on the transition of the patient, of a child, from the primary to the permanent dentition. There is very little attention that was given to this transition in the research, in pediatric dentistry or orthodontic research when it comes to eruption of the teeth. So the way, when you look at the size of the permanent teeth and the size of the primary teeth, there is a very dramatic difference in size. So the nature designed our jaws so you don't transition from the primary dentition to the permanent dentition all at once. There are special sequence of eruption that is pre-programmed to happen in each child, and a certain number of teeth will erupt at certain age, and then there will be a little kind of resting period, and then more permanent teeth erupt. So that resting period is accommodating for the growth of the jaw and the growth of the follicle of the tooth that is happening inside the jaw to allow those teeth to erupt safely in the oral cavity. And safely, in my eyes, means that the tooth erupts with enough gingiva and enough bone supporting it from all around it. What is happening to children today, we know that the faces of children are not growing properly. They are not growing forward enough. They are not growing wide enough. So there is a traffic jam inside the bone before those teeth erupt. It's like everything is, all the follicles of the permanent teeth are pushed back and inside the bone, and they start changing their orientation inside the bone before they erupt.
Mm.
And in some children, when the jaws are so small, those follicles will basically perforate the bone, make a hole in the bone, like moth eating the bone, on the outside, on the inside of the jaw, that by the time those teeth erupt into the oral cavity, they will not only not have enough gingiva, but they will not have even enough bone around them by the time they reach the position in oral cavity. So that all can be diagnosed early. And believe it or not, I am a strong believer that you don't need all this fancy 3D imaging to diagnose it. There is a more simple way to diagnose the problem in a younger age using very simple clinical indicators. But the CBCT is excellent to use for educational purposes. So we have some CBCTs already of children that had very severe deficiency. We can learn a lot from those CBCTs. So CBCTs show that if you have severe crowding, that the buccal and lingual bone around the tooth, that is so important, because that's the bone that is going to support the root of the tooth for the rest of the patient's life, is already eaten away before the tooth even makes it into the oral cavity because of the crowding. So if you can address it in a younger age, you can avoid all of these complications. So this is what I would like to teach orthodontists, and especially pediatric dentists and also periodontists that are developing all these fancy bone and soft tissue grafting technique to regenerate the bone that is not even there by the time the tooth erupts, because we are missing the window of treating it in young kids. So
That's
it's not only the airway. The airway is a big component too. The airway in a younger child is more of a cause of the poor jaw development. And then when jaw fails to grow right, it's a vicious cycle that kind of closes, that it compounds on the compromised breathing through the nose. But so you have to break that vicious cycle as soon as possible. You have to optimize that nasal breathing, lip closure, tongue to the palate posture, and that has to happen in a young age. Even between age 4 and 6 is to some extent some of these problems already late to fix. We are not preventing anything. We are fixing the problem that already is there. But when it comes to eruption of the teeth and development of the follicles of the teeth and preventing gum issues, periodontal problems later in life, I think under age 6, you can still make a difference.
okay.
Patient.
Do you think this is something most periodontists aren't even aware of?
Well, the periodontists are trained to treat the problems, the defects that already exist. The prevention part of periodontal education and treatment has everything to do with already existing periodontal disease. So you are not preventing periodontal disease unless you are a restorative or general dentist when you see the patients regularly every 6 months before they develop the disease. Mm-hmm. The periodontist sees patients that already lost the teeth, are about to lose their teeth because of bone loss and gum infection and periodontal attachment loss, or they are there to treat those periodontal defects when they already need treatment.
Yeah. I wonder if periodontists would even be over. Yeah.
It's too late to prevent the recession from progressing when recession is already there, or when the patient doesn't have any attached keratinoid tissue. Mm-hmm. We have to do it earlier. The question becomes, how early? What is the right age? Mm-hmm. Well, the minimum that we can do is actually treat a child in the primary, diagnose crowding, diagnose small jaw problem in a younger age, make room for those follicles of the permanent teeth to allow those teeth to erupt with sufficient gingiva and bone around them. And that is totally possible. And I will show cases in my course that will reflect what we are talking about, that you can improve periodontal support with proper, healthy, improving and facilitating healthy eruption of the permanent teeth.
And it makes perfect sense. Like that's
This
so
is
clear. And
logical.
it's so
It's
logical.
so logical. And how did we not think about it 50 years ago?
Exactly. It's same with like the whole airway and our jaws are shrinking. It's just so logical. It makes perfect sense. Our teeth are crowded. Our jaws are not large enough to house our teeth and we're choking on our tongues. Like all this is so logical, but it's so surprising that it's really taken so long to get to where we are. And there are many people who still doubt or are treating with traditional methods or not working to prevent, right? I have a question about you said CBCT might not be needed to diagnose these issues. There's some clinical indicators. Are you able to talk about what some of those clinical indicators might be?
Well, one of the very simple clinical indicators is looking at the face of a child from the side. If the upper and lower jaw are recessed and not ahead of the forehead, automatically that child doesn't have space for the teeth. Because in order for the teeth to have space in the jaw has to be certain size and certain distance to the rest of the cranium. And if that jaw is recessed, I will show you case after case. I have not seen a patient, in other words, I have not seen a patient when I look at the face and the face is recessed that had normal development of the teeth.
Mm-hmm. Yeah.
So this is like, in other words, like we as dentists are used to look in the mouth before looking at the face. This
Mm-hmm.
is thinking the opposite way. Let's look at the face first and estimate what is happening inside the mouth if the face is growing this way or that way.
Mm-hmm. Mm-hmm.
And once you start looking for these things, you will be surprised, because there is, if the upper and lower jaw are too short and not growing forward enough, you will rarely, I have not seen one
Mm-hmm.
patient that has no crowding if the jaws are recessed.
Mm-hmm. Mm-hmm.
They could be in a crossbite. They could still crowd. Doesn't mean that no crowding is not equal to have spacing between the teeth, because the patient could have spacing between the teeth and still have crowding, not enough room, if the teeth are severely flagged. So, for example, if the patient has low tongue posture, has huge obstructive tonsils, and the only way for them to be able to breathe and to be able to um, function properly is to hold the tongue forward and on the lower jaw. You may have spacing between the lower teeth, but those teeth will be flat. So you have to position them virtually on the basal bone axially in order to diagnose if you have enough room for them or not. So just because clinically you see spacing doesn't mean somebody is not crowded.
Mm-hmm. That's a good
Because
point.
spaced out teeth could be flat, and flat teeth are not, this is not healthy either. It's not the normal physiologic position in the bone.
Mm-hmm. And a lot of the adult expansion techniques involve not just expanding the bone, but then uprighting the teeth because due to all that compensation, right? So decompensating the teeth
Mhm.
in order to provide, you can't go back and like fix the periodontal problems, but it'll help prevent future periodontal problems when the teeth are decompensated.
Yes.
If you'd like to watch the rest of the episode, run to our website and become a member today.